Okay, so I promised you guys I would not leave out the parts about how to evaluate a patient in the depressed phase as well as evaluate a patient in the manic phase. So I'm going to start with the evaluation of the depressed state in bipolar disorder. Over a lifetime with bipolar disorder, most patients are going to have more depressed episodes than manic or hypomanic episodes. Now, I said that a lot in the subsequent video, but it's a point I want to drive home, not only for people who are planning to be psychiatrists or working in the mental health field, but also for patients to understand that depression is much more common than these other states. A patient is more likely to consult me or ask for help from me when they're in their depressed state. They're less likely to come in hypomania specifically, but also mania, at least voluntarily. Sometimes patients are brought into the hospital involuntarily in a manic state, but a lot of times they're going to present to you in outpatient practice in their depressed phase. So what we want to do there, and the important point about this, is that we want to screen all patients who meet criteria for major depression for a lifetime history of mania. And that is to avoid improper diagnosis, because the treatment and medications, when they design research studies, they design them specifically for a disorder. So they're going to look at patients with just bipolar disorder when looking at bipolar medications or medications to treat mania, let's say. So we want to make sure that we're making a correct diagnosis, because the treatment is vastly different between somebody with just major depression and somebody with bipolar 1 or bipolar 2 disorder. Another interesting fact that I want to bring to your attention is that first-degree relatives with bipolar disorder actually increase the risk for major depressive disorder, not bipolar disorder. And it's not always a reliable way of making the diagnosis, right? So some people might think that if I just identify a first-degree relative in this person's family with bipolar disorder, I can automatically say they're bipolar. That's not really a good way of going about it. It helps build the case if you're suspecting bipolar disorder, or you're thinking based on this person's, evaluation, that they probably have a bipolar disorder and not just a major depressive disorder, then the family history of bipolar might help build your case. But again, you want to be mindful that it's more likely to be depressed and have major depression than it is to have bipolar if a first-degree relative has a bipolar diagnosis. I want to talk a little bit now about the diagnosis of depression in general, because I think it's pretty much the same as if I were screening or working with a patient for major depression. I'm going to ask similar questions, and we're going to look for similar criteria, DSM-5 criteria, to diagnose that person. So, what you're looking for with depression is you're looking for a 2-week period where the person has had either depressed mood or loss of interest, and then they need to have 5 of the 9 symptoms that I'm going to talk about here. Now, this is a very clever mnemonic. If you've gone to medical school, or even if you're in mental health in general, you've probably heard this idea of SIG-E caps. Now, that mnemonic comes from, it's a little bit of a funny story, but the idea is that this is the way you would write a prescription for somebody with depression. You would want to prescribe them energy capsules. So SIG is a shorthand thing that we use when we're writing prescriptions, and then again, energy capsules to treat their depressive symptoms. What does it stand for, though? Maybe that's the more important thing here. So the S in SIG-E caps is for sleep disturbance. Now, it can either be increased sleep or decreased sleep. So somebody could either have what we call hypersomnia, where they're sleeping more often, or they can have insomnia, where they're having difficulty falling asleep and remaining asleep. But sleep disturbance is very, very common in major depressive episodes. I is for loss of interest, and I already said anhedonia is another term for loss of interest, and that's just where the person loses interest in previously pleasurable activities. So if I like working out, I then suddenly don't find any interest in working out anymore. I don't enjoy it the way I used to, right? We want to look for loss of interest in previously pleasurable activities that the patient engaged in. Guilt can stand for a couple of things. Obviously, there can be guilt about, missed opportunities, guilt about family interactions, but there can also be things like hopelessness, feeling like nothing is ever going to change or get any better, or worthlessness, where you basically feel like you are not worthy of anything or anyone, and that's another form of guilt. E is for energy, so decreased energy is going to be the case with depression. Increased energy would be the opposite with mania. So decreased energy with depression. C is for concentration, and normally I will ask about concentration in a different way because not everybody is in school or studying some difficult subject matter or something like that like we're doing here. They're not going to have the same type of concentration issues. So I'll usually ask, are you able to read a chapter in your favorite book without losing your concentration? Are you able to watch your favorite TV show without losing your concentration and focus on it, right? I'll use something like that in day-to-day life that will help the person to kind of understand, oh yeah, I'm getting, my concentration has been off a little bit. Appetite can either be increased or decreased. Generally speaking, with depression, we think about decreased appetite and weight loss more commonly, but sometimes people have what we call reverse vegetative symptoms, and that can include things like increased appetite or what we call hyperphagia. Psychomotor changes. So a lot of times with depression, and you can go back to this with mania as well, mania will have psychomotor agitation, whereas depression will have psychomotor slowing or retardation in most cases, but there can also be psychomotor agitation in depression. So you want to be mindful of some type of psychomotor change in your patients. And the final one is, of course, suicidal thoughts, and maybe the most important one because, like I said, 30% of bipolar patients attempt suicide at some point in their lifetime. So we want to be mindful of suicidal thoughts, and we want to do a thorough suicide screening on these patients as well. And that will pretty much conclude a basic introduction to how you might approach the depressive phase of a patient who presents for potential bipolar disorder. I'm going to cut this video here nice and short, hopefully easy to digest material. And if you're enjoying the videos, if these are helpful to you in any way, please like and subscribe to our channel. It helps us to keep making this type of content.